Good morning or good afternoon, depending on where you are in the country. My name is Mark Perino. I serve as the president of the American Association for the Treatment of Opioid Dependence, ATOD. This is one of our webinars, which has been supported through SAMHSA and through the aegis of the Opioid Response Network. And we are a partner of that group, and that's managed by the American Academy of Addiction Psychiatry. To provide some context to this webinar, this is a part 2 of the webinar we did on July 16th. That was with Dr. Patty Juliana, Dr. Nicole Smith, and Tracy Weymouth of SAMHSA. In July, they provided an update of the regulations, where we stand with it. This webinar today is going to focus more on the provider response to those regulations. And as you know, the SAMHSA regulations for the OTPs went into full effect in October of 2024. Obviously, there's been a great deal happening contextually in our field. On the positive side, there's been a real increase in the number of programs. There are now more than 2,124 operating OTPs in the country. In addition, there are 71 operating mobile vans, and there are about 123 fixed site medication units. That means that you have a push out of the OTPs into rural and underserved areas. Now, today you're going to hear from Dustin Metz, the CEO of CompDrug in Ohio, Chrissy Martin, National Director of the Midwest Division of the BHG Group, and Robert Lambert, the President, Executive Director of Connecticut Counseling. They're all experienced people, clinicians and administrators. Dustin represents the Ohio programs to the ATOD Board of Directors. Chrissy represents the South Carolina programs, and Robert represents the Connecticut-based programs. They're going to respond to the regulations, how their programs, how some of their colleagues in their respective states have responded, have dealt with these issues. And it's positive news. They'll talk about some challenges as well. I can tell you that some of the challenges that we've been dealing with at the national level have been related to third-party reimbursement in general, and have been dealing with the issues of how some states have interpreted or misinterpreted the issues around counseling. I'll just say this at the outset, that the issue here is that when SAMHSA released the regulations, their intent was not to abolish counseling. In fact, when you read the regulations with care, they will indicate that all of the operating OTPs need to maintain a complement of clinical personnel to provide comprehensive wraparound services in addition to the medications that are used in the treatment programs. So, to be clear, some states have interpreted that counseling is not required. That is simply not true. The regulations only get into this matter when it specifies that if the patient is not getting counseling, you can hold back medication. It does not say that counseling is no longer required. So I want to clear that up at the outset. Obviously, and you see the background is we're having our conference in Philadelphia, which starts October 4th, goes through the 8th. These policy issues will be certainly discussed in much greater detail. So before we begin with Dustin, I just want to say that as a reminder, and I brought this up during the July webinar, ATOD and NASADAD worked with Westat, a subcontractor to SAMHSA, in January and the first quarter of this year. And we were doing this to get a real survey of the reaction of how the programs were responding to the SAMHSA regs. Even at that time, in the first quarter of this year, over 90% of the programs implemented changes based on the SAMHSA regs. Over 70% had eliminated the 1-year pre-treatment requirement. And then over 70% eliminated the 2 prior unsuccessful attempts at withdrawal for people under 18. And then over 80% of the programs have been providing more take-home medication. So those are some of the basic issues. What I can say in general is that patient censuses have increased throughout the country. Again, it depends on the state, depends on the regulatory management, but we have seen an increase in patient admissions. A good part of that is related to the fact that the pre-admission history of opioid use disorder has been eliminated. Also, as treatment programs have increased the initial doses of methadone, as most programs know, it went from 30 milligrams to 50 milligrams on that first day of admission. As a result of that, and for the programs that have done that, they have seen an increase in retaining the patient during the admission and titration dosage period. Additionally, as medications have been provided in more take-home, we've also seen a significant increase in retaining the patient in care. This is all a way of saying that SAMHSA, because it was so well thought through, and they certainly worked with all of the stakeholders in this field, including our association and member programs and state opioid treatment authorities, that there has been a really great opportunity to respond, and the programs have acted accordingly. So this is positive news. Now, there are challenges, which I've talked about, and now that we'll get into the more specific issues of the presentations, I know that my associates will address those as well. So first one up is going to be Dustin Metz. He's representing the Ohio programs to the board, and certainly he's the president and CEO of Comptroller, as I said. So Dustin, go right ahead.
Awesome. Thank you, Mark. I'm going to skip ahead. Where I'm going to focus, I think, is what we've done in Ohio. But before we do that, it's important that you're thinking about where your state is and where the alignment is with federal law, state law regulation, and what you can and can't do. Because sometimes there's great alignment. There's really an overlap between what the state is intending to do, what the state regulations say, and what the new Part 8 regulations allow you to do at the federal level. And other times there's alignment in some areas and not others. And let's be honest, there are some states where there's not alignment really at all. Those are really challenging. We happen to be here in Ohio, and if that last one describes your state, reach out. ATOD can help you identify other people locally. If you have a state chapter, we'll get you in contact with them so that you can start advocating on how you really can get better alignment within your state. I'm going to focus a little bit on Ohio. Ohio, kudos to the state of Ohio. As soon as the notice of proposed rulemaking went out, we were working with our SOTA and our state agency, which is OMAS. It's going to have a name change here in a couple of days to the Ohio Department of Behavioral Health, but at the time it was OMAS. And also our Board of Pharmacy. Our Board of Pharmacy really understands OTPs and not only the work we do, how federally we're required to do that work. And they try to make sure that the state regulations are not A, an impediment, but B, amplify and align with those federal regulations. So Ohio, we're in a good spot. We've got 130 OTPs. That is a growth from 2014 of 4 times. We've also seen an increase to 40,000 patients being served in the state of Ohio. During that same time, 2018, we had around 15K. We are serving more people because we're all on the same page, from regulators down to providers, of what is necessary and how we approach providing opioid treatment in the state of Ohio. So talking about intent of the state, we also need to think about what is our perception. What do our peers in behavioral health view of us? What do our peers in physical health view of us? What do the other social service and police organizations, how are we interacting? How are we viewed? And for the most part, it's not a real positive view, right? The new rules shift that. We were born out of a criminal justice response, whether out of necessity to get it through or out of a need to have an impact in a system that they knew they needed an impact at that time. Over the years, we knew then and we know now, this is a medical, a behavioral health intervention. It has an impact on criminal justice, but it is a medical or behavioral health intervention. Do we act like that? Right? Or do we act like it's still a criminal justice intervention? How do your patients perceive you? How are the regulations aimed? In other words, when you read the regulations, do those regulations address you as a medical or behavioral health provider, or do they address you as a criminal justice response? And probably most importantly, and what I'll talk about here in a sec, is how do you view yourself? How do your employees view what you do, what we do? Because how we view ourselves will transmit to how we treat patients. So we realized early on, right? We have a nice alignment at the state level. We have a progressive view on treatment in the state of Ohio. Boy, how are we going to implement these regulations? We're going to need to both change what we do, how we do it, and we're going to need some help. So we took an approach of looking towards technology. So if you're going to give a week of take-homes at admission, which is now permissible, how are you going to do that with the nurses or whoever within your state? We are required to use nurses to prepare those doses. What if you got somebody who's stable with split doses on a month? That's 54 doses. How are you handling that coming to your window as a nurse? We implemented a dose assembly automation system. Allows us to quickly prepare those doses so that the nurse can be interacting with the patient, not just preparing the doses. Those doses are then, they're pumped, capped, labeled, foil sealed, and it happens at a rate of 400 per hour. So the practical consideration of how do we implement these relaxed regulations was met by using some technology. The beauty of it is that it also attacks a theme that you'll hear, which is the patient's perception. How are they treated by us? It's stigma. Our nurses have a positive impact because now they're doing nursing activity. Our patients no longer have to be in the clinic any longer than they have to be in the clinic. So their experience on a day-to-day basis has improved. The nurses' experience has improved, which means in turn, the nurses have a better disposition with patients as they interact with them. It's a virtuous cycle. But preparing doses is only one aspect. The other aspect is how do we safely know that the patient is, there was resistance early on, especially from our medical team, of how are we going to assure safety? How are we going to avoid diversion? Well, let's see what else we can do. Bring in another technology. So like Zing, we have implemented Sonara. Sonara is it's a virtual dosing window at its heart. It allows us to continue to daily dose, even though they're dosing with the take-home. So every day we have an interaction with a patient. It just isn't physically at the clinic. On some of those days, it's virtual. We've gone for everybody coming in, basically receives 4 take-homes a week. They're alternated. They're either on a Monday, Wednesday, Friday, or a Tuesday, Thursday, Saturday. And then they receive their additional take-home for Sunday like they always did. It really moves away from that earning take-homes. Like there's some stick and carrot that's involved in this. medication that is meant to stabilize and keep them in a good place. It means that we have those daily eyes on. Nurses are able to engage patients in their care rather than penalizing them or viewed as penalizing. Share a story. The day we went live with Sonara, we had a patient, had been with us not quite a year, was absolutely convinced that recovery was not going to work for her, was in tears, was struggling, not because she didn't know what to do, right? She's never had a test with us that wasn't positive for fentanyl. Couldn't go more than 10 days without medicating, without a miss that entire time. Why? It wasn't because she didn't want to try. It wasn't because she wasn't motivated to do it. It took her 2.5 hours of bus time to arrive at Comtrod. She's caring for a grandchild, recently lost her adult child, full-time employment, doing well at her employment. She didn't have the time. The life wasn't allowing her to have recovery. Or was it we didn't have the tools to allow her within what she could do to have recovery? When she shared of Sonara, and now she is dosing and receiving those, we still have eyes on. We still interact with that patient in a way that now meets her ability to have life. And that is everything. Another story, two-way communication. Something we would never have by having a patient come into the clinic every day. Had a patient, took their dose perfectly, right? So this all happens on camera. You're observed. Took the dose. Patient panicked, and we could see it on camera. Oh, it didn't record it. It recorded. It was fine. We were able within 24 hours to have a two-way communication through the app with that patient, assuring them not only did they record, but they're doing great. And we're having totally a different experience for that patient. What would that patient have done without those interactions? What kind of stress? It is amazing when we allow the use of that technology to augment what we've always done and to critically look at what we're doing. Another aspect that we're really excited about are virtual take-home callbacks. So really using as a screen for our primary first line use of take-home callbacks. Screen them, kind of a telehealth using the app, allows us to see if there's an issue. If there is, we're going to call them back in and do the normal callback procedure. But now we can do a lot more direct observation without having to have somebody come in 2.5 hours for a trip. Non-emergency medical transport, finding a bus, finding all of those costs, both in money and time, that come either out of someone's payer pocket or their ability to live life. At the end of the day, this all enhances safety. It does increase patient convenience. And to be honest, for our nurses and staff, allows them the ability to have great interactions with the patients. So what has it led to? As Mark was talking about, we've noticed an 8.5% increase in retention. That is just from taking our starting doses up to 50. It is from adopting that 4 take-homes per week, reducing trips in, and despite the team's concerns at the outset that it might lead to problems, we've experienced no excess sedation or increased overdose risk. In fact, it's all been positive for the patient. And this is 8.5% increase before we did even Sonara. Sonara just went live about a month ago. So we do not have the data yet on what that is going to do for us. So far, anything I didn't cover here? No, you'll have the slides. So let me jump into what everybody is, I think, talking about. And we internally had this conversation as well. Guys, the rule doesn't say this, right? Everybody is saying, oh, counseling is still a component of care. It is the critical component of care. What is no longer required is using it as a wedge for medication, which it never should have been in the first place. If you were CAR for credit, if you were accreditation at all, you should not have been using medication as a wedge. Would we, in any other scenario? In fact, I would challenge you that even in your own practice, if someone came to you and said, I'm going to require you to have counseling, and you would fight that tooth and nail because you're the professional. You know what's best. You know, in concert with that patient, that client you're serving, what they need. Not some regulator from Columbus, not some regulator from DC. That is a relationship that is important. You'd fight it. So it is interesting that when the regulators are saying, look, this is yours, you need to be the professional, there's pushback. And I think we really need to think about recovery and what the patient needs to be fully functional, not what we're required to provide to that patient. Because if we're giving the patient what they need, that is patient-centered. Otherwise, it's clinician-centered or it's regulatory-centered. We're not doing for the patient what they need. I'm sure you're all familiar with the stages of change. So can I guess, in this, ask where are you? Shock, denial, anger? Oh, wait. That's the wrong stages. What is the challenge? What is your resistance? Why is this a regulatory model that needed updated? Are you concerned about safety? Have you examined the potential upsides of these changes? Not focusing solely on, oh, how am I going to meet with my patients? Are they going to meet with me? Let's worry about meeting them and their needs. And it sounds easy, it sounds nice, but it truly is all we've got to do. Now, is that easy? I don't know. But you do have to be prepared. Are you okay that this is their journey and that it's going to be a long journey? And we've got to help them along. So the research is clear. They need treatment. So how are you going to motivate them to want it? Right? That's the gist of this and the internal conversations we've been having. How are we shifting from something that was a stick to something that is, they need to want it. They need to know they're going to benefit from receiving it. It's work, right? It's tough, but it's not just you. You have a team. Everyone on your team should be focused on motivating that patient to succeed. Not punishing, quote unquote, not holding, not when they don't do something we want, right? Focus on what we need to focus on. Now you have a very, clinicians, I think, have a very critical component of that team, but you can only play that part. You'll need everyone else to help you, right? So stop grabbing the bars. The cage is open. You need to fly. You need to be the professional you were trained to be. You need to use the skills that you were trained to use. And everyone believes in you, right? You've got this. And you've got it because we've got your back. How do we change our systems to support you in doing that? Counselor shared an anecdote with me. During a session, the patient was kind of a little happy, a little scared. Is this true? Take homes are no longer tied to counseling. Quote, yeah. So I don't need to come and see you anymore if I don't want to. That's correct. They went through the rest of the session. At the end, the patient said, so can I still schedule with you for next month, right? Yeah. That moment that patient was able to exercise true autonomy for maybe the first time related to their counseling. That's a very good thing. It's a very good thing. Why is a patient going to come back to you? If they have to come back to you, and they have to come back once a month, guess how many times they're going to come back to you? Likely once a month. If they know they're getting benefit from you, they know that what you're providing is giving them the care they need, they're getting better. They're solving their issues. They're dealing with those ancillary issues because they're stable on medication and they're working on the other stuff, right? Get your brain stable and now you're working on the mind. That's what we are supposed to be doing. And that's what these regulations do. So take a step back, think about how you get to that point and not focus on what you no longer have to do. It's important to understand every single interaction, no matter how small, how large, is therapeutic, no matter who provides it. Could be a peer, could be a receptionist, could be a person that is just cleaning, the restrooms. Every single one of those interactions is important. And let me take that. So the person I mentioned before that on video thought that they had taken the dose wrong and it had not recorded, and they were, what was that? Was that a technical issue? Was that the technology is not working because I can't tell if it's, no, that was an opportunity. It was an opportunity because that event showed the patient had a low tolerance for stress. It was visible on screen. The information critical to be understood by not the medicating team, right? Not the nurses, the counselors. So how do we get that information? We have systems that will help get that information to where it needs to go, because that is something that counselor can now assist with, because I can guarantee if it's showing up on this, it's showing up in other aspects of that individual's life. So kind of in summary, yeah, some of our clinicians were feared, our jobs at risk. No, but how you do your job is going to change. And some were they felt free because they can finally focus on the patients who really need the counseling, not the ones who are there because they have to be there for the 1 month session. In other words, we're more effectively using these professionals' time, your time, to serve the patients who most want your care and need it. That's a very good thing. Now we got to work on motivating the others into wanting it, but that's a different consideration at this point. You can now focus your time on what's most important. And that's that thought of reaching new patients, resetting the expectations not only of our clinical staff, but of all staff and of patients as they come in. Now we've got to motivate that. We can't just require it. Again, it's a shift in the environment. It's using everybody as a team. And overall, I think this highlights it. We can't keep doing the same things we've always done and expect different results. Try something new. Don't be afraid. The regulations are freeing you to be able to meet the patients where they are. And I think you will find that those results are excellent. So thank you for the time. Oh, and Mark, you're on mute.
Well, Mark, if it's okay with you, I can go ahead and start.
All right, Chrissy, go right ahead. And Dustin, thank you once again. I know that you'll join us when we get to the questions. So Chrissy, please begin.
All right. Well, hi, everyone. As was mentioned, my name is Chrissy Martin. I'm the current chairperson for our South Carolina chapter of ATOD and serve on the ATOD board. And I'm also a national clinical director with Behavioral Health Group, which operates opioid treatment programs in many states. So I've had the opportunity to see this unfold in several state environments. I'm going to focus primarily on our South Carolina experience, since that's what I've been kind of most closely involved with. But I may touch on a few kind of multi-state provider challenges as we go along as well. So first, just quickly, here's our landscape. This is the landscape of opioid treatment programs that we have operating here in South Carolina. We have 29 opioid treatment programs here, soon to be 30, I think. And all of the programs here are represented in our ATOD state chapter membership, which has been really helpful for us to mobilize in a pretty unified way in response to some of the changes that we're here to talk about. I'll give a quick plug. I'm also the membership chair for ATOD, so I hope that you guys see through this experience kind of the benefit of participating in your state ATOD chapter. And if you're in a state that does not have an ATOD chapter, that you might see the benefit of potentially looking into forming one. So feel free to reach out to me if you have questions about how to get connected or plugged into your chapter or how to start one if you're in a state that does not have one. So, in South Carolina, very, very similar to what Dustin shared, we also kind of moved pretty quickly as soon as the final rule was first went into effect in April of 2024. One of the first things that we did was a side-by-side comparison and assessment of our state regulations to begin to identify where we had misalignment with the updated federal rules and provide clarification to our field and to our members on where programs could go ahead and start following the new federal rules, and also where they were going to be unable to follow the new rules due to a more restrictive state regulation or a regulation that was continuing to use some of the old federal language. Aside from just wanting to give clarity to our members, we also wanted to use that information to give guidance on how our state should consider amending our state regulations here in response to the federal rule change. So we reached out to our SOTA here, and we were able to convene a meeting with our SOTA, our State Drug and Alcohol Authority, and our licensing agency, who's also our regulatory body here. And this meeting was primarily, I would say, educational, intended to inform the licensing body of these federal rule changes, of which, they were pretty unaware. And then to make that recommendation that, hey, we think that you should amend our regulations here to align with this. And that was a very successful meeting, I would say. They were very receptive to that. So not long after that meeting, they did initiate the rulemaking process. Now, in the meantime, anticipating that the rulemaking process would take considerable time, we submitted several requests to the agency for exceptions to the regulations to ensure that our members could go ahead and start operating under the new federal rules. So we looked at kind of 3 key areas where we were going to continue to be kind of hamstrung by state rules. We looked at the initial dose limits, criteria for determining take-home eligibility. We didn't have anything in our state rules that bound us to time and treatment restrictions, but it did still use the old language for determining that eligibility for take-homes, and also the elimination of the 1-year history of addiction criterion for admission. So outside of the regulatory change process, we were also concerned about a South Carolina law pertaining to telehealth and what that might mean in terms of our ability to utilize the new provisions in the federal rules for telehealth admissions. A law had recently been passed in South Carolina that limits the prescribing of scheduled medications via telehealth. They, in that law, had created a carve-out for buprenorphine treatment for opioid use disorder, but not for methadone. And so there was some concern among our members about how that could potentially be applied to our setting. So we requested one of the medical directors here in South Carolina with one of our kind of longest standing OTPs down here, if he would present to the South Carolina Board of Medical Examiners, which he did. And again, a very, very successful outcome there. They then used their authority to issue an order that expressly allows telehealth admissions in the OTP setting. So I would say, on the whole, all in all, we've had a very positive, very collaborative experience here in South Carolina in trying to move our state environment into greater alignment with the new federal environment. But that said, things have stalled a bit. We're well over a year later, and we still don't have final rules published here. There was a pretty significant restructuring of state agencies that happened here. I'm sure that's part of what has caused some delay in the rulemaking process. And so we're still operating here under these exceptions that we submitted. Despite that, I would say that the South Carolina programs here have largely amended their policies and their practices in accordance with the exceptions we're operating under, and in good faith that the final rules here in South Carolina are going to establish more permanent alignment with the federal rules. But I do want to acknowledge that it's kind of an uncomfortable middle. This was a quote from one of our providers here. They said, we're experiencing a lot of positive impacts, but on the flip side, we do find that some of our staff still feel as though we're in this gray area since they're still working off the DPH exceptions and would feel more comfortable knowing what the final South Carolina regulation will reflect. So, I think the feeling is that things are still a little unsettled, a little unfinished at the state level. And I would say that that's not unique to South Carolina. One of the challenges that we've had as a multi-state provider has been navigating the rulemaking process in multiple states with wide variation in what their processes are, the degree of communication, the degree of collaboration, and ultimately the degree of alignment with the new federal rules. There's always been these kind of significant differences state to state that the OTP community has had to navigate. And as the state regulatory landscape kind of continues to take shape in response to the federal rule changes, it's not super clear whether we've taken this opportunity to really narrow those gaps and narrow those differences state to state. So these are just a few more quotes from some of our members. Just despite the kind of current lack of permanence that we're operating under here, I will say that programs are reporting a lot of change and a lot of positive outcomes. The change I probably hear the most about from our members is just changes to practices around the provision of take-home medication and just what that's done to make treatment more accessible to patients, improving their satisfaction, and really just making treatment easier and more enjoyable. One provider that I talked to talked about feeling as though they no longer have to spend so much time talking to patients about take-homes or about their frustrations with take-homes or their attendance schedule, and how that's really freed them up to talk about the things that really matter and how it's really facilitated improved therapeutic relationships with her patients. So I thought that was really, really great. So definitely here in South Carolina, we're seeing programs really utilize this new, individualized and patient-centered decision-making process for deciding, making decisions about take-homes. I want to mention here that there's really been no discernible changes in South Carolina around counseling. I know that's, Dustin talked about that. I know Mark talked about it at the start of the meeting here. And I know that this has been kind of a murky area in some regions, but it really just has not entered the conversation here. Our programs, they provided counseling services before these rules changed, and they have continued to provide those counseling services since the rules have changed. I would say another impactful change that we've seen here in South Carolina has been the expanded use of advanced practice providers. This has been really critical to make services more available to patients. I would say particularly around admissions. It used to be like, oh, these are the days that the physician's here. Those are the only times we can admit. Now we have really been able to have more provider availability and more admission availability here in South Carolina, which has been huge to improve access to care. one unexpected outcome that I wanted to kind of just touch on briefly, and I want to preface this by saying I'm speaking to this from a place of total neutrality. But we did see some providers here in South Carolina after the rules change make some decisions to close an additional day during the week. It was something that I don't think that we were really anticipating, but that happened. I think some of these programs, particularly some of our maybe smaller and more rural programs, had a long history of operational and staffing challenges, particularly on those weekends. And we have some additional pharmacy requirements here that make it even more challenging in South Carolina. But I'll say that that decision has been a little bit of a point of disagreement between our state authority and our provider community. And it's a little unclear still, I think, how that might shake out. So I did want to share some slightly less anecdotal data, or at least some visuals with you all since the federal rules have changed. And while we don't track this at the state level in South Carolina, my organization, Behavioral Health Group, like many organizations, has been tracking this internally. At BHG, we amended our policies and procedures on the provisions of take-homes fairly quickly when the federal rules changed, and provided a lot of support and guidance to our providers. And we've seen a definite shift in take-home schedules and attendance of our patients. The majority of patients, probably closer to about 2/3 of patients, are now attending only one time per week or less. It used to be that our kind of largest bucket of patients were patients that had to attend daily or almost daily. Now, the largest bucket of patients we have are patients that only attend one time per month. And we've seen that number of patients that have to attend daily or almost daily really shrink significantly. Not quite to zero, which I wouldn't expect, both because we have patients who may still need that higher degree of monitoring and support. But also, this data includes some states that have continued to have more restrictive or prescriptive rules around than the federal rules do. And then we're also really trying to identify, what are all the kind of sorts of positive changes that we have seen resulting from these changes to take homes. And something that's been really interesting to see is that as the average number of weekly take-home doses per patient has increased, we've actually seen improved engagement in counseling services from patients. There could be, some other factors at play there for sure, things like increasing use of telehealth for delivering counseling services. But this could also connect back to that potential for improved therapeutic relationships with our patients when you take out some of that frustration and tension out of the equation. And we're certainly continuing to evaluate the impact of take-homes on retention. I know Mark mentioned that. We're particularly interested in that. And we're really honing in on the impact in early treatment and trying to parse out and refine our systems for identifying patients that have barriers, for whom take-homes really early on are going to really help facilitate their retention. But we're also seeing some indications that there may be some new patients for whom early take-homes, at least at a certain kind of number or volume, may be a catalyst for early dropout. These may be patients who may benefit actually from being in the treatment milieu more often, to establish that helping alliance that with the treatment team, that we also know is a really critical factor in early retention and OTP care. So, we don't want this to become another version of a one-size-fits-all approach. So we're really, we need to continue to evaluate all this data to help really guide our individualized decision-making. So again, still a lot to learn, I think, from these changes, but also a lot of potential, a lot of exciting things, I think, that we're learning. So in thinking about what's next, obviously there's still some finalization in the state rulemaking process that needs to happen, both here in South Carolina and in other states as well, before we can kind of fully understand the new regulatory landscape. But even still, there's a lot of opportunity now for OTP partnerships, to really begin or further leverage some of the opportunities that we have under these new rules, things like telehealth admissions, mobile units, that can really continue to close some of those gaps on access to care. I do think that there will be a need as we look ahead to evaluate payment models. Payment models must support our program's ability to provide individualized, patient-centered treatment. We should make sure that the payment models we're using in this new regulatory space support doing the right thing for the patient and don't incentivize doing the wrong things. There are some payer models where programs are not paid or they're paid less for days of take-home dosing. And with more patients receiving take-home medication, this could have some impactful consequences. Now, that said, my organization and other organizations that I've spoken with are very deeply committed to just doing the right thing for the patients. But the cost of providing these services is not changing. And so continued and sustainable support from our payers is going to be really essential moving forward. And certainly, in addition to these rule changes, there's some additional changes on the horizon that our systems are going to have to navigate as we realize the impact of some of the recent federal legislation and what that's going to mean for our patients' coverage for care. But there may be some opportunities there as well. You know, the Rural Health Transformation Program specifically calls out supporting access to OUD treatment in the approved use of funds. So this funding opportunity, coupled with these new flexibilities under our updated federal rules, may really open up some opportunity. And so, you know, states are beginning to form their plans and their applications for those funds right now. So now is really the time to seek out those opportunities, those partnerships, and make yourselves heard. All right, and with that, I will pass it along to Rob.
So Chrissy, I thank you. You covered a lot of ground quickly, and I'm grateful. We are starting to get questions coming in, and I'll provide, after Robert's remarks, I'll provide some clarification as we open for questions. So Robert, the Connecticut counseling perspective and Connecticut's perspective.
Okay, sorry about that. I was still on mute. I'm assuming, Chrissy, you can see the presentation up. Okay, great. Thank you. Okay, as Mark mentioned earlier, my name is Robert Lambert. I'm the President and Executive Director of Connecticut Counseling Centers, and also the President of the Opioid Treatment Provider Group of Connecticut, which is a Connecticut ATOD chapter, and also the Connecticut Board Delegate for ATOD. So as you can imagine, I'm going to give you the Connecticut perspective on the implementation of the new SAMHSA regulations. And as Chrissy mentioned, obviously every state is different in terms of their individual state regulatory structure and how that interfaces with the new rule, and obviously how to what degree OTPs can adopt the SAMHSA new SAMHSA regulations. So in Connecticut, just to give you a little bit of context, in Connecticut, we have a little bit of a smaller state. We have 33 community-based OTPs operated by 10 different organizations. My organization, Connecticut Counseling Centers, operates 5 of those OTPs. And in Connecticut, we have 3 state agencies that have oversight over OTPs and whose regulations will impact the way OTPs can operate. The first is the Connecticut Department of Mental Health and Addiction Services, and this is the home to our SOTA. And DEMIS also provides some funding to OTPs. They also manage the SOR funding, State Opioid Response Grants. And we also have the Connecticut Department of Public Health that licenses OTPs, and the Connecticut Department of Social Services, that is our state Medicaid authority. So prior to implementation of the final rule, our SOTA was very active reaching out to the other state partners, and at the same time aligning her agency regulations with the new SAMHSA regulations. So, I had to give her a lot of kudos. She's very proactive, and she understood that in Connecticut it was going to be a challenge to get all the state agencies on the same page. So she's been working with her state partners at DPH and DSS to try to align the regulations. And I'll talk more about that, more specifics in a couple minutes. So right now, in terms of where we're at in Connecticut, we have not been able to achieve full alignment. We've been able to partially implement the new SAMHSA regulations, and I'll give you some specifics around that. But we're still working towards full alignment. And again, because of the efforts of our SOTA, those talks are ongoing, and there is progress being made. And we look forward to a point in the not too distant future when all of our state regulations will align with SAMHSA. And our SOTA has also been very active working with the OTPs. She attends our state chapter meetings, and has been working very closely with us, and has truly been a partner in the process of transforming the way OTPs operate in Connecticut and aligning with the SAMHSA regulations. So just real briefly, I'm just going to run through what we have been able to implement and what we have not been able to implement. So I'll start with what we have been able to implement. The first is the elimination of the 1-year history of opioid dependence. We've been able to fully implement the flexibilities with methadone dose induction. And I think most OTPs now are starting at 50 milligrams if appropriate, or higher if it's medically justified. Mid-level practitioners now have the ability in Connecticut to admit and prescribe without an exemption. And this is, like Chrissy mentioned, this has been really key to opening up access to OTPs. The bottom line is, especially for our smaller OTPs and the smaller organizations running them, covering the clinics can be very, very difficult. In Connecticut, and I'm sure you're experiencing it in other parts of the country, there's a real workforce crisis that we're experiencing, both in terms of licensed counselors as well as medical personnel. So this has really helped the OTPs expand access. And we've been able to align with the SAMHSA regulations in terms of unsupervised doses right from the beginning. And I'll talk a little bit about what that looked like when we rolled it out. And obviously, we've always been, well, in Connecticut for a number of years, there's been a concerted effort to promote and work towards a more patient-centered approach to care. And we've been working on removing stigmatizing language for quite a long time. But the implementation of the new SAMHSA regulations was another motivation to keep working in that direction. There's a few things we've not been able to implement, and the first is the patient autonomy in regards to engagement in counseling. In Connecticut, mandatory counseling is still required, a minimum of once per month, and this is a regulation, or this is a requirement embedded in the regulations of the other two state agencies that have oversight over us. So we're not able to implement this at this time, but we're working towards that. And frankly, we're looking forward to the point where this can be implemented. And I'll talk more about why that is in a couple minutes. We are, in the meantime, really working at Connecticut Counseling towards looking at how we're defining counseling and the content of counseling, and ensuring that the counseling that is going on is patient-centered and in alignment with the patient's wishes. One of the things that we've been talking about for a long time is, sometimes it's helpful to take a look at how you're defining counseling. Because in my experience, what really turns a patient off and creates that resistance, and which ultimately will affect the therapeutic relationship, is the content of the counseling much more than needing to come in and do counseling. So are you meeting the patient where they are, to put it simply, right? So we really encourage our folks to focus on where the patient is and what they're ready to talk about and engage in. Of course, engagement and working on the therapeutic relationship and the therapeutic alliance being, for us, the top priority of that interaction between a counselor and the patient. Physical exam, the two-part physical exam with the initial screening, with the option of telehealth, and the full assessment within 14 days has not been implemented. In Connecticut, the state agencies still require the full physical exam to be completed prior to admission. The physical exam must be completed by an OTP practitioner in Connecticut. So we are not allowed to take advantage of the flexibility to use a physical exam from an outside provider. In the meantime, while we're working on changing that regulation, the state has allowed individual organization to apply for an exemption to be able to accept a physical exam from a hospital. This is something that I know a few organizations are working on, although as far as I know, these exemptions have not been granted yet, but that's kind of a stopgap measure until the regulations can align. And in Connecticut, the blood work, admission blood work, has to be completed within 14 days rather than the SAMHSA rule of 30 days. So I'm going to talk a little bit about the implementation of the changes that we have been able to move forward with in Connecticut. And I think our experiences and what I'm hearing around the state are very similar to what other organizations have experienced. So when we first looked at the proposed SAMHSA revisions, it became very clear to us very quickly that this was going to be more than just a matter of revising policy and procedure. That this, in fact, was going to require a real shift in how we approach treatment. And internally, we decided from the beginning that we would really need to completely reconstruct the OTP clinical model. Revising policy and procedure, honestly, was the easy part. The more difficult part was designing and implementing this model across all of our clinics. So we started with a leadership retreat, wanted to make sure leadership was on board with the direction we were trying to go in and what our goals were. We created this new paradigm of how we're approaching treatment, created some guiding principles to help the staff at all level walk in the same direction. And those guiding principles and that model then drove the revision in clinical policy and procedure. And of course, then there was a process of rolling this out to our 5 clinics and providing ongoing training and follow-up supervision. There were a few bumps along the way in implementing this new model. And the one that I really wanted to focus on most today is the change of clinical orientation or the change of clinical culture. Because, Chrissy and Dustin talked a lot about how these revised regulations at the end of the day help clinicians create a more therapeutic environment in the OTPs. That change was going to be key to making this work. And, I could tell you with some of our staff, and I think other organizations in Connecticut experienced the same thing, they looked at the new model, they looked at the new policies, and were thrilled. I heard from therapists who said, finally, I feel like I can act more like a therapist and less like the program, rule enforcer. So I think most clinical staff were very happy with the change. However, there were some that had difficulty with it. And in my experience, those that have been working in the field for a long time, worked within that more historical structure, are the ones that if they were struggling, tended to struggle the most. So it wasn't as easy as just changing policy. It took a real sustained effort over a long period of time to really change the clinical culture in a really profound way. So there were some staff objections, some overt, and we addressed and worked through them, some covert. And when I say covert, I don't mean that there was staff that were sabotaging the process. Um, in these cases, again, I think some clinicians had real difficulty, letting go of the old model that was much more controlling in nature, much more focused on the clinician's assessment and not as much on the patient's perspective. Just real quick, I want to talk about a couple of different groups that struggled a little bit because I think that the nature of their struggles was a little bit different. So the first is the medical staff. Some of our medical practitioners were very happy with the change and excited about it. Some struggled with it. The ones that struggled with it, from my observations, struggled with letting go of the historical caution that they would have in both dosing and providing or prescribing unsupervised doses. And, when I looked at this, it became very clear to me that it all kind of comes down to where that practitioner is setting the bar in terms of benefit and risk. So SAMHSA, when they were rolling this out, talked a lot about the risk-benefit analysis, that clinical decisions are no longer criterion based, more based on the risk-benefit analysis that the clinician engages in. And it was clear to me that a lot of the practitioners were kind of working within the context of having a very high bar in terms of the stability that they expect and the amount of risk that they were willing to endure in prescribing, specifically in prescribing unsupervised doses. So it became clear that we needed to look at changing that bar. The bottom line is this, when it comes to unsupervised doses, our folks, especially early in recovery, not always, but tend to have a lot of issues that they're dealing with, a lot of psychosocial issues that they're working through. And, from a clinical perspective, if all you're focusing on is the risk, it's fairly easy to make the case that that person shouldn't have unsupervised doses because there's a lot of what ifs with, what's going on in their life. So the shift for us was really focusing more on the benefits. And my director of clinical operations said it best when he was telling the staff, there are times when you need to weigh the benefits more highly than the risks. So it came down to changing that paradigm for our practitioners and how you go about doing that risk-benefit analysis. And I'll give you a really quick example. A lot of our folks who miss medication on a regular basis miss because they don't have reliable transportation. Well, what happens when they miss? They're at high risk of relapse. And we all know that one use out there with the fentanyl that's out there could be the end, right? So they may be unstable in other parts of their life, but if we can't get them the medication they need every day, everything else is for naught. That I think is a good example of where, the benefits of the unsupervised doses, ensuring that they get access to the medication every day, eliminating those transportation challenges or at least reducing them was much more important than the potential risks that are involved in areas of the life where they're not stable. So again, it's shifting the paradigm, changing that bar, or changing the calculus and how you do that risk-benefit analysis. There was, again, the overarching goal that we really talk about all the time with staff is engagement and retention has to be the top priority. So as you're making those clinical decisions, this is one of the gauges on the dashboard you should be looking at constantly, right? Is what I'm doing in increasing engagement and increasing the likelihood of retention, because that's priority one. And then there were a lot of liability concerns. Well, I'm the prescriber. What happens if all the ifs come about. And so we had to work through that. We consulted our attorneys as well as representatives from the insurance industry, and came up with a plan to manage that. And the bottom line, I'm sure a lot of you are already aware of this, the best way and most realistic way to manage liability risk is adequate documentation of the decision-making process. And we had to work on that with them because many of them are used to just kind of making a decision and that being the end of it. With our counseling staff, we had a mixed reception. Again, some took to it like a fish to water, whereas others had a problem letting go and adopting the new policies. And in most cases, from my perspective, it came down to control versus patient autonomy. I would hear things from clinicians like, I can't let the patient have unsupervised doses because A, B, C, and D, right? I can't let them make that decision because of A, B, C, and D. So we really had to work on changing that dynamic. Not that everybody looked at it that way, but there definitely was a artifact from that historic model that needed to be addressed. And then the other issue, I know I've talked to Dustin about this, and I know he sees it too, is I think there's some fear and anxiety on the part of counselors in terms of their need to exercise clinical muscles that they haven't exercised in a while. There's a big difference between making a decision based on checking the boxes versus actually using your clinical muscles, clinical decision making, and then justifying that decision, right? So I think for some clinicians, they haven't used those clinical muscles in a while, and there was a little bit of anxiety about that. And then for other clinicians, maybe those muscles were never adequately developed to begin with. So one of the things that we're focusing on in my organization is really that, ramping up the amount of training we're doing with counselors internally, including focusing on motivation enhancement therapies. Um, so, the bottom line, and I think that all organizations in Connecticut are experiencing this, this new paradigm was adopted sort of at different rates, at different OTPs. I can tell you at mine, data collection has, which we've always been doing, really helped in terms of targeting those OTPs that really needed more guidance and assistance. I'm getting close to the end of my time. I just wanted to share some of the guiding principles that we developed and worked on with staff as we were rolling this out. And these are the ones that we found particularly helpful. We focus on every level of this new paradigm and the shared practitioner-patient decision-making process, respect for the patient perspective and autonomy being the top priority. Again, risk-benefit analysis and decision-making versus criteria-based decisions. And it's not just the SAMHSA's old criteria for unsupervised doses. Counselors historically tend to have sort of a set criteria in their mind in terms of what defines a stable patient versus an unstable patient. So it's working with them to step outside that box and work on those clinical judgment muscles. Level of patient autonomy should be no less than any other medical behavioral health care practice. I know Dustin and many of my other ATOG colleagues have talked a lot about this as well, that, obviously historically OTPs have been the most regulated form of behavioral health care. These changes allow us to move towards a more therapeutic environment. So, we often will talk about this internally in our clinics. It's like, compare what we're doing to an outpatient behavioral health care practice that's not an OTP. Is the level of patient autonomy similar? I've always used the family question. Would you send your family member to see you, Counselor A, given the way that you're treating that patient or you're applying the program rules? In terms of unsupervised doses, in general, we went from, doses have to be earned to doses should be the expectation. So, instead of, it used to be if a patient didn't have, a significant number of unsupervised doses, the assumption would be, well, they don't qualify for them, or they don't want them. We had to really shift to a position in terms of supervision where that's questioned. And the question should always be, why not? Why doesn't this person have it? It really should be the expectation. Unless, there's some variable there that clearly would preclude providing them. So again, the clinicians now need to make the case, if this is operating correctly, make the case for unsupervised doses, and defend that. And again, I mentioned this earlier, but the benefits of unsupervised doses may be weighted more highly than the risks. And the other guiding principle that we've been following, we used to put a lot of emphasis on checking for diversion and controlling for possible diversion. The data during the COVID pandemic revealed that, when we did expand unsupervised doses, we really didn't see any negative effect. So, kind of shifting that focus from, checking everybody for diversion to just looking when there's a reason to look. So again, the primary role of the clinician is to provide a clinical service, right? To provide a therapeutic environment for the interaction or the transaction between the patient and the clinician, not to police or attempt to control behavior. And, again, I think for most therapists, this has been real welcome change, because the bottom line is, and I've always said this, that if you could be a therapist, a real effective therapist and an OTP, you could do therapy anywhere. Because historically it's been so difficult to be an effective therapist because of the dual role of compliance officer, program rule enforcer. This is moving us away from that. And this is really where we are looking forward to the time when our state regulations fully align, so we can take the step and really apply this to counseling services. All right, so I
So
think I
we're
already
gonna wrap
talked.
up we're gonna go to the questions now. So if you could just wrap up in the next minute.
Sure. Sorry about that. I tend to go a little long. We have some initial outcomes that I wanted to share with you. We have seen a increase in admissions. It hasn't been consistent across all OTPs, but we have seen increase in some. We've seen a significant increase in unsupervised doses at Connecticut Counseling. The number of doses increased by 30%, and we had a corresponding decrease in the number of missed doses. Decrease in number of discharges. One clinic decreased by 16%. And as Chrissy mentioned, there's been an increased interest by non-OTP organizations to collaborate and join with OTP programs to streamline services. And we're working with the Connecticut Hospital Association to do just that. I think that we'll continue to collect data. So far, the data looks very promising, but we'll continue to collect that as the other state regulations in Connecticut align with SAMHSA. So, thank you. I'll end there.
All right, Robert, thank you. All right, so let's go to the questions. There are questions for all three. We'll start with Chrissy. There was a question about the data you showed, the difference of patients in rural areas versus the more urban areas of South Carolina. Do you have that breakdown or differentiation?
I don't have that. That was actually not even a snapshot of just South Carolina. That was across the BHG footprint. So that was in many state environments and both very urban programs and very rural programs. So we don't have the ability to parse that out. But that certainly would be really interesting to look at. My sense is that our more rural programs are definitely leveraging this opportunity to make the ease of getting to treatment better for our patients that have to travel pretty significant different distances to get to our programs.
Okay, thanks. There's a question that probably all three could address, but we'll keep it brief. There's a question about the benefits of less restraint on unsupervised dosing and then higher doses during induction. The question is are there data about these risks and as overdoses and diversions? What I've heard from you, but also broadly over the last several months, is that we're not seeing any shift or increase in diversion or problems in terms of overdoses as more take home is provided. Is that a fair assessment? That's for all of you.
It's a
Yes.
very fair assessment. In fact, I think what we're seeing is the impact it's having isn't a negative impact, it's a positive impact. They're getting to a therapeutic dose quicker, and we're having that blockade happen much sooner. So in other words, where you would normally have somebody who spirals out, and this isn't because you're not getting them to where they need to be, we're able to get them there now. And so in essence, this is a part of the medical side of meeting them where they are. The expectation that they would stop using, fentanyl or street without being at a blocking dose is, why would you not get to the blocking dose? It's self-defeating. So what we're seeing is the evidence that tells us we should have been doing this all along.
So there's a question also related to this, which is some programs are reluctant to provide take-home medication during the patient induction phase. This is driven by it's a practical medical stabilization matter, especially since 75% of the admissions or more are using fentanyl. And as the programs are increasing the dosage and now at a higher dosage level faster, is there a concern about giving take-home medication during the medication induction period where the questioner is wondering, is the risk in that period higher?
I can take this one initially and then pass it off to others for comment. At my organization, we made the decision to have folks come in. We're open 6 days a week, so have folks come in Monday through Saturday just for the initial induction period. We also put exceptions in place where, if the patient is going to disengage from treatment because of issues related with coming every day, we're going to look at that because, again, our top priority is engagement and retention. But for the most part, we have folks coming in every day just for the initial induction and then start take-homes. And the reason is our medical staff is more comfortable with seeing them every day, especially if they haven't been a patient prior. And in doing that, I think the staff is also more comfortable in titrating the dose much quicker than they would be otherwise. But a lot of programs in Connecticut feel the same way. Others do things a little bit differently. I think for me, it comes down to what is the comfort level and orientation of your medical staff. But most of the programs that do require folks to come in every day, it's just during the first initial steps, and then they move to take-homes pretty quickly.
And Mark, I would add that very concern is what led us to look for a technological solution that would assist. So while patients leave with maybe 4 take-homes a week, maybe a full complement of take-homes for the week, they're not without us having eyes on. So they're still virtually dosing in front of a nurse every day. We're watching, we're observing. We're actually having two-way interactions with those patients. How are you feeling? You don't look like you're too hot. To my surprise, those are actually starting to be some rich conversations. I thought it was going to be ignored a little bit by but I didn't realize patients would engage that way so quickly. I think it's probably a sign of the times. That's how we interact these days. We're all comfortable doing that. Why wouldn't that be a way that they would be comfortable interacting with us? So we do have eyes on, even though they're not coming into the clinic.
Well, there's a note that should be made, and you've made it, but I'll sort of emphasize it. Keep in mind for the programs listening, remember, you still have state regulations in effect. It's not just the federal regulations that we're dealing with. And historically, generally speaking, the state regulatory environment tends to be a bit more restrictive. Also, reimbursement at the state level, in this case, Medicaid reimbursement, will be tied to program services. So it depends on whether you have a fee-for-service rate or a weekly bundled reimbursement rate, the way Medicare has a weekly bundled reimbursement rate. The point here is that you have to then consult with the state authorities. And I can say to you that during the conference on Sunday, October the 5th, SAMHSA is convening a meeting with all of the state authorities in the United States to talk about these sorts of policy issues and this concept of alignment. So to some degree, this is still a live breathing issue. And there was another question that I can respond to, which is, when do these regulations at the federal level become fully implementable? They are. They became fully implementable in October of 2024. So for programs, for states, whether you have pharmacy boards, that's sort of the reality. So a question to all of you could be, should programs or could programs consider adjusting their dosing hours since more patients are getting take-home and there's a decrease in the amount of clinic visits? Do you have any particular perspective on that?
We've actually done that in some of our, especially our smaller clinics. We've significantly reduced the number of hours we're there for Saturday because we have so few patients coming in on Saturday now. And even in our larger clinics, we've reduced the dosing hours. We have to be cognizant in doing that we're still meeting the patient's needs in terms of when they're available to come down. But yes, it definitely has resulted on the weekend anyway in reduced dosing hours.
And Dustin, here's a question to you, since you brought this up about the Sonara app. Is there any further brief consideration you can give about how that Sonara app has been working and its success?
Yeah, so we implemented Sonara at the beginning of September. It's been amazing for both our nurses, who are the primary users of the app. We're primarily at this point implemented the virtual dosing window, so it is really a virtual way for those nurses to do. Technically, they're self-administering, but they're observing that administration and reviewing it, then communicating with the patient. The nurses love it. The patients have been, they're loving it too. It is designed around the least capable phone. It's not an app, it's technically a web app. It's very easy to use from the patient's perspective. And 1 month in, everyone's loving it. Now let's get 3 months in and see what happens.
Okay, it's a fair issue. The question has come up about any model titration schedules, and I'm assuming the question is about induction dosing. And I know that this varies by patient, and it should. That's the whole point of individualized patient care or patient-centered care. And I know that there has been a benefit of retaining the patient with a more assertive titration schedule, titration being upward. Any point of view, any comments on that?
I'll just say, I don't know that I have a titration schedule that I can share necessarily, but I will just share our experience has been, we are trying to kind of identify those patients that we can or should more rapidly kind of induct. And we've found that the ability to start at a higher dose and to titrate more rapidly has probably been more impactful on retention even than some of the take-home flexibilities. It's been a really important to get patients to that therapeutic dose as soon as possible so that they know that they're going to benefit from the care that we're providing.
And from my perspective, this flexibility, the change came at a really important time because we were already trying to deal with fentanyl. So having that flexibility in dosing has really assisted us to help the patient with their fentanyl dependence.
So once again, a question that could apply to all of you. The question is, in working with counseling and clinical personnel who still retain beliefs that there have to be consequences for the patient not engaging with their counselor, how are you dealing with that? And that's a question I know that's come up from a lot of programs. And so it's a reasonable question. So it goes to the issue of how we've shifted this paradigm. Again, you have state regulations that may not have, as has been discussed. So what is your experience in dealing with clinical care when you have, let's say, counselors who still think that there need to be consequences?
I would start by taking a look at that individual counselor, their skill set, the clinical muscles that they have or they may need to develop. So I think for me, I would advise my supervisors and my directors, and they do this it can vary from counselor to counselor, but I think it starts by trying to get an understanding of what their paradigm is, what their clinical experience is, what their clinical skill set is, because oftentimes it really stems from a misunderstanding of what the clinician's role is. And sometimes, in my experience, counselors will fall back on a more authoritarian way of doing things, not because they want to be authoritarian, but because they don't have the skills to do it another way. So I mentioned, increased focus on motivation enhancement therapies within our organization. That's just, another reason why we do that. But I think it boils down to taking a look at why that individual clinician feels the need to operate from that place.
A question has come in also about telehealth and the difficulties of adopting it, especially if the states are not aligning. So what we have heard in the national office is that telehealth has had a huge difference in increasing the use of mobile van services. And we have heard that telehealth has also had a significant impact on inducting patients. So do you have any wisdom about how programs can adopt telehealth services if they're not doing so at the present time?
I'll just say, I mean, I do want to acknowledge, I think this has been like a tricky landscape to kind of figure out, because in addition to the federal rules, we've had to kind of, as I mentioned in my portion, kind of evaluate all of these additional layers at the state level and payer level as well, I'll say, and kind of what's allowable, what can we do via telehealth. But I just want to say that, there's a lot of opportunity out there, a lot of easy technology. It's easy to get free technology to be able to start and do telehealth. And it's been really, really valuable, I would say, for us at BHG. We've used telehealth to make sure that we can almost provide admissions to patients all the time. If we don't have a provider here on site, let me see if I can set you up with a telehealth visit with a provider at another site and get you admitted today and right now, because right now is when you're here and when you're ready. And so that's been really critical. And I would extend that to counseling services as well. We've, for some patients, really seen better engagement in counseling services that are, delivered at their convenience and not kind of tied to our very early programmatic hours.
So I'm going to wrap up now because we're getting close to obviously the conclusion at 2 o'clock, and this is out of respect for both the participants and speakers. I think it's fair to conclude that the SAMHSA regulations have ultimately ushered in a new and improved era of really being focused on patients, and that the idea of patient autonomy is important. And I think, we have to be careful about not misinterpreting regulations. And again, you need to have increased alignment with the states and the federal regulations. And that's why SAMHSA is convening this meeting with the state authorities next Sunday on October the 5th. So with that, I'm grateful to SAMHSA as always for their change and support to the Opioid Response Network, which it provides the grant funding for these series, and obviously to Dustin, Chrissy, and Robert for sharing their experience and understanding. I'm grateful, as I am to our colleagues in the treatment community, and certainly for Angeline Budia, who coordinates all of our webinars, for setting this up and making sure that this is a favorable experience to our many participants. I hope to see many of you in Philadelphia. If you think this was helpful, I can assure you that spending 5 days at a conference that focuses on all of these different aspects is extremely important and valuable. So if you haven't done so, you should consider registering and getting to Philadelphia. And also, something that Chrissy said, it does make really practical sense for programs to work together in the respective states. If you don't have state chapters, you should think about forming them. And whether or not you join ATOD is up to you, but obviously we would recommend it because, you know, the concept of unity is helpful, not just from an organizational perspective, but practically what is delivered to the programs. So I hope you've enjoyed your time during this webinar. I hope you've learned something. This has been recorded. So for those of you who have participated, you will get the recordings. There is a survey that we're going to ask you to complete once the webinar comes to its conclusion. And the survey just basically helps provide guidance for our webinar series. So with that, again, I hope that this has been helpful to you. And you'll get, for those who want these CEOs, you send in your request, and certainly Angelina will respond to the requests that come in. So thanks again for participating. Thanks to ORN for supporting this endeavor. And again, I hope to see you in Philadelphia and what promises to be a very good landmark conference as well. So thanks again. Enjoy the rest of your day.